My name is Henk Giele. I'm a plastic and hand surgeon in Oxford, and I'm passionate about thoracic outlet syndrome, partly because for reasons like the story I'm going to tell you about a 21-year-old nurse who was going through her training and was doing her anesthetic attachment in the anesthetic room with my anaesthetist when she complained of arm pain behind her elbow. And the anaesthetist, who's obviously worked with me for a while, laid her hands on the nurse's neck and said, "We've got a lump there, you should go and see Henk." And it transpires that this young girl, since the age of 9, had had pain in the posterior aspect of her elbow with swelling. And she'd had multiple scans, she'd had several biopsies. Because she remained undiagnosed with this posterior elbow pain, she was eventually referred to the psychiatrists and psychologists because they felt she had some psychological issues for the cause of her pain. She had a MRI scan, which was reportedly normal, despite the fact that her X-ray looks like this. So don't trust MRI scans. And she had a palpable mass in her neck. And on exploration, she has a cervical rib with an articulation that was compressing or irritating C7, giving her posterior triceps elbow pain discomfort. You can just see it there. And there's the first, cervical rib with the first rib excised and the anomalous large articulation causing the problem. And there it is, removed, and her problem's resolved. And what you can see here is her subclavian artery had a middle trunk here. This is her upper trunk, and here's where it's been irritated. And so it's stories like that where people are misdiagnosed or undiagnosed, who then, in fact, have a real problem, but may be thought to be mad. Hopefully you're all here listening because you have some sort of interest in thoracic outlet syndrome or in undiagnosed difficult conditions. And I hope that from this talk, you'll get some better understanding about thoracic outlet syndrome, or at least think about it when you have a patient in whom you don't know what's going on and why they're not responding to your treatment. So we're going to cover thoracic outlet syndrome. Unbelievably, some people think it doesn't exist. And so we're going to consider why people think it doesn't exist, consider the evidence for its existence, the diagnostic criteria, or to expand all of that, those issues plus how you examine for it, what is the treatment, the outcomes, and what happens when it recurs. Does it exist? Well, it obviously exists. So people who deny its existence are in fact like anti-vaxxers or COVID deniers. So there. It obviously exists because no one would dispute a patient such as this 61-year-old fit man, previously completely neurologically normal, who has a very displaced clavicular fracture and who progressively loses neurological function and sensibility in his arm. So he has some neurological compressive or some other pathology caused by his fractured clavicle, which is causing his problems. So people would immediately agree that that is a recognizable condition. Treatment of here, of course, is to reduce the clavicular fracture and fix it. Same with this lady, a fractured clavicle, progressive loss of neurology, and fixed by orifying the clavicle. No one would deny the existence of this condition, sudden occlusion of the axillary vein, causing venous dilatation, swelling of the hand. You're right, it's Pathophysiology syndrome, and people wouldn't deny that because it's so obvious and there's real hard evidence of occlusion of the vein, and you can do a venogram that shows the venous supply is occluded. And there's lots in the literature about that. sudden occlusive phenomenon of the subclavian or axillary artery causing ischemia, like this guy with digital ischemia, 22-year-old gentleman, previously fit and well. He suddenly got occluded subclavian artery, ischemic finger. The artery was reconstructed by the vascular surgeons, but they didn't do anything to repair his, to decompress his thoracic outlet. And he got quite bad neurological progressive disease of his median ulnar nerve, which resolved following decompression of his thoracic outlet. Because it's so obvious and because it's so definite, people wouldn't deny this. So here's a patient with ischemic hand. Again, sudden occlusion. You can see she had some discomfort in her forearm. She had a forearm bandage put on, and that was sufficient because of her poor vascular supply to cause necrosis of her forearm skin. And you can see, even with her arm depressed, this hand's normally vascularized, and this hand is ischemic. And she's got an ischemic ulcer in her little finger. Little finger was numb, and this occurred suddenly. Here she is again. Occlusion on her angiogram, and at operation, a very tight scalenus anterior compressing and occluding the subclavian artery. And this was the point of occlusion. It obviously been going on for some time because she's got post-occlusive dilatation. And this section was resected and repaired. Slightly more challenging and perhaps a little bit more less decisive is somebody who presents with intrinsic wasting involving the lower trunk, like this patient here, not just wasting of her intrinsic muscles, but also the abductor pollicis brevis, altered sensibility in little ring finger, sometimes middle finger, and the medial cutaneous nerve of forearm. And more pictures of the same. And another guy who's got intrinsic wasting, one hand, normal in the other, and a Horner's syndrome, and yet another patient with the same intrinsic wasting, clearly from the lower trunk, unilateral, so it's not likely to be Charcot-Marie tooth, Horner's syndrome, slightly crazed impression, he's got thoracic outlet syndrome. And yet another patient. This patient is also demonstrating the thumb little finger test. And of course, these patients who have positive neurophysiology consistent with motor loss in usually the lower trunk, but can be elsewhere, and loss of the medial antebrachial sensory nerve action potential are easy to diagnose and to say they are consistent with thoracic outlet syndrome. So they're the easy ones. They're the obvious thoracic outlet syndromes. And so you can understand why there are people who don't believe in thoracic outlet syndrome, the anti-tossers, because if they just believe in the obvious, clear things, then they're ignoring the rest of the pyramid of people who have less obvious symptoms or who have milder symptoms before they get the vascular occlusion or before they get the neurophysiological changes that convince people that they have thoracic outlet syndrome. And there are lots of people in this sort of spectrum. The size of the circle is small for the obvious people. And then the next ring out are people where you're pretty sure have thoracic outlet syndrome, because for like this patient here, who's got costoclavicular compression with some symptoms when she carries objects or when she pushes her shoulders back in a military brace position, and her cause is a clavicular spur from the clavicular clavicular-humeral coracoid ligament, and this is compressing onto the plexus. And having removed that resolves her symptoms. But because there's an obvious finding, that puts her in the sort of pretty sure bracket. But there are a large number of people in the possibly, probably have thoracic outlet syndrome, which are the ones where the diagnosis is difficult. This is the lady with the spur. You can see the spur here compressing on her plexus, particularly when she retropulses her clavicle and shoulder, and there, once it's removed. So most of this discussion concerns these group of people, possibly, probably have thoracic outlet syndrome. And the difficulty with their diagnosis, because it's very hard to have definite evidence that this is the cause of their problem, is that it's a EQ diagnosis. It concerns a feeling that that's the problem that's going on for them. Some of the feelings rely on some facts in their history and in their examination findings, but the facts alone don't give you the diagnosis, unlike the people with obvious thoracic outlet syndrome. So it's very much this type of diagnosis. And it's that type of diagnosis because the symptoms are very varied, and they are varied not just in type. So some people have pain, some have paresthesia, some have numbness, some just complain of fatigue, some demonstrate wasting, that makes life easier, some have swelling or color change, some have weird symptoms like headache, pain in the tongue, facial numbness, paresthesia, hearing things. So these symptoms are nondescript, indistinct, and they can be very varied in their site as well. So they're not always just classically in the little finger or the medial side of the hand. They can, like that nurse, occur in the posterior aspect of the elbow in very oddly localized areas, depending on what aspect of the nerve is irritated or compressed or has altered function. You can try to discriminate the symptoms as to whether or not they are mainly nerve related. So things like pains, pins and needles, numbness, heaviness, weakness, a tremor, functional loss, color change, swelling, change in sweat, hair growth. All those things are a bit more neural related from those that are sometimes more vascular related, where people complain of weakness when they do things, when they put their arms in certain positions. Some people complain of claudication and compartment type syndrome symptoms, cold intolerance, things like that. And of course, there's mechanical things like feeling a mass in the neck, like this young lady here, or some patients who complain of clicking when they roll their shoulder. Everybody has a thoracic outlet, and so there's some element of thoracic outlet syndrome that can be provoked in a lot of people, but it may not be problematic, or it may not be problematic now, but it could become problematic in the future when your nerves become less tolerant or when your anatomy or mechanics change. The other problem is we don't quite know what the pathophysiology of the symptoms are. It's very changeable because it depends on positioning and posture and stress on the nerve, including nerve tension, and because it's sometimes related to the nerve, sometimes related to the vessel, arterial or venous. We do have a framework or a hanger to try and understand what's going on, because pathology is very similar in many occasions to nerve compression. And we all know and believe about carpal and cubital tunnel. And we all know that some carpal tunnel is very obvious with lots of signs, symptoms, and neurophysiology. And some of it is obtuse, where the symptoms can be very different without neurophysiology and without signs. Like a lady I had recently who had pain in the back of her hand, but that was carpal tunnel syndrome. But we digress. And you know from nerve compression that the type of symptoms that people can present with can be very diffuse, hard to describe, and non-specific in some occasions. When you're trying to put all this together, it's important to know the anatomy so that you know to what muscles and what dermatomes relate to which nerve roots and along its course, because the pathology or the lesion can be anywhere along the course of the nerve. To help localize it, you need to have a good idea of the anatomy, the relationships of the nerves to each other and to the other structures in the neck, particularly the scalenus anterior lying in front, scalenus medius behind, and the first rib. And this triangle, and then bounded by the clavicle on the top, is sort of the key area for most of thoracic outlet syndrome, or the area below the clavicle and under pec minor can sometimes also be an issue. It's good also to have a rough idea of the topography or the internal topography of the nerve, because that also helps sometimes to localize where the lesion can be, because a compression element on the anterior division of the upper trunk can affect the suprascapular and give you posterior shoulder pain, as opposed to something that's affecting the posterior aspect of the middle trunk, for example, giving you different symptoms. And of course, it's important to know about all the different variations that are possible, but all of these things aren't definites, and that's why the symptomatology and the presentation is so variable, and everything needs to be kept with an open mind. So the diagnostic criteria for thoracic outlet syndrome are this. There aren't any. There are, this guy Paulson did a Cochrane review of all the RCTs in thoracic outlet syndrome. These weren't specifically to look for diagnosis, these were to look for treatment options. There are 3 RCTs, one about cervical traction, one about first rib versus first rib transaxillary or neurolysis supraclavically, and the quality of these were very poor. There's a great deal of bias, and but that's the sum of the evidence, and there is very little evidence about the diagnostic criteria. Some people have tried, these are vascular surgeons from Washington U, who've tried to put together a core outcome reporting set. So this wasn't a diagnostic set, this was an outcome reporting set for reporting outcomes after doing surgery for thoracic outlet syndrome. And they mainly concentrated on pain, pins and needles, and limb tension tests. You can read all this on the handout when you get one. It is considered to be a diagnosis of exclusion, because in these cases where there are no hard signs or symptoms, then what you're looking for is to make sure that people don't have the common problems, carpal tunnel, cubital tunnel syndrome, for example. But the list of differential diagnosis is long and ever increasing, particularly if you break down things like the weird neuropathies. And within the weird neuropathies, of course, there are subdivisions and diagnostic difficulties. So you don't need to know them all, but you do need to consider all the possible other diagnoses that are more difficult, that are more easy to determine. And you also must know about your shoulder assessment, because rotator cuff symptoms, for example, can present very similar to thoracic outlet syndrome. Apart from the excluding everything else, listening to the symptoms and getting a feel for that the symptoms might be related to thoracic outlet syndrome or the neck rather than something more peripherally, you try to elicit signs that may help you to make the diagnosis. So I do a normal brachial plexus examination of sensibility, all the peripheral nerves and motor power and range of motion. I also look at the patient's posture. So thoracic outlet patients often have a slightly kyphotic appearance, a pecking neck, short neck. They may have some abnormality of the contour of their neck, which I'll show you. So that's a common sort of postural abnormality. You may determine that they have sensory change. Again, the medial cutaneous nerve of forearm coming off the lower trunk is quite a key finding that I look for where the lower trunk's involved. And of course, all the exclusive tests to exclude things like carpal tunnel syndrome, cubital tunnel syndrome. And I also run through a list of provocative tests. And so these are mainly described for vascular changes. So using the pulse as a measure for what's happening to the adjacent nerves, because they're all traveling together, and you obviously get a more rapid response to the pulse than you would get to the nerves. And so you feeling for the pulse whilst you do these provocative motions. Now, I did have a video, but I can't find it. So I'm going to try and demonstrate this to you now. This is Gus. Say hello, Gus.
Hi.
They can't hear you, actually, because I'm on a microphone.
Oh.
So, Adson's test is you feeling the pulse. It's a vascular test. You can't see me, can you?
Henk, if you stop sharing, then we'll be able. Yeah, now we can see you very well. Yeah.
Okay, sorry, I forgot. I thought, because I could see me.
Yes.
Carlos. Okay, this is Gus. I'm going to go through the provocative.
Hello, Gus.
Test.
Thanks for helping.
He can't hear you because I'm on the headset, but never mind. So I'm feeling the pulse, and these are pulse tests. So I'm feeling for the strength of the pulse. And some people have a poor pulse in a working position. So if they hold their hand out to write or type, so I'll just get them to hold in that position first. It's not an eponymous test. It's just one to know that if their symptoms provoked in a working position, what happens to their pulse like that. Some get symptoms when their arm's dependent, when they're holding something. And so you're feeling the pulse like this as well. Wright's test is a hyperabduction test, feeling the pulse up here. You remember it because when you know the answer, you put your hand right up in classroom. Adson's test, you adduct the arm, AD for add. You look up at the sun, so Adson's test, and you look towards the affected side. And what this does is stretches the scalene, just like it stretches sternomastoid. And then you tell them to take a little breath, take a big breath, and a little bit downward pressure on the shoulder. And again, you're feeling the pulse. So change in the pulse or loss of the pulse or provocation of the symptoms is a positive test. Reverse Adson's, you examine when the scalenes shorten or contract. So if I put my hand here, push down on my hand, and this forearm is pushing on the shoulder, this hand's feeling the pulse, big breath in, good, that's reverse Adson's. Naricus test feels the pulse at 90 degrees with some traction. It's like a nerve tension test, but also puts the subclavian artery under tension as it passes under the coracoid and under pec minor down the arm. Falconer's military brace position, or Halstead's military brace position, shoulders back, up straight, grab both arms, put it behind the body and pull down. Good. And then we get you sitting in a chair. Let's move the chair here. Good. Good. You do range of motion of the neck. And whilst you're doing range of motion of the neck, you do the cervical rotation lateral flexion test. So you turn the head away from the affected side and then flex the neck. And then you turn it towards the affected side and then flex the neck. And towards the affected side should be a slightly reduced in rotation and also reduced in flexion. Cervical rotation lateral flexion test. Sperling's test to check for again, to exclude a radiculopathy, a little bit of extension, downward pressure, and then tilt away from the side. So this will compress the nerve roots on that side or compress the nerve roots on this side. So if they get symptoms like this down this arm, it's likely to be a radiculopathy. If they get symptoms like this down this arm, it's likely to be brachial plexus tension. And then Roux test, if you're like that, and then open and close your fingers. Roux did this for 2 to 3 minutes, and you see if you elicit pallor in the hands or fatigue or cramp in the arm. The most sensitive test for me is Morley's compression test, where I'm feeling the plexus. So my fingers on the clavicle roll up over the clavicle, so you're cranial to the clavicle. Index fingers feel sternomastoid, and then behind sternomastoid, you can feel scalenus anterior, the interscalene groove, and then you just rest your fingers there, putting some light pressure. Whilst my fingers are doing that, my thumb is feeling the back of his neck. So the patients think you're feeling the back of their neck. And so they say, oh yeah, so it's kind of a way to catch them out. If they go, oh yes, it's painful behind my neck, but they report nothing in the front, it's probably not thoracic outlet syndrome. If they say, oh yes, it's tender where my fingers are and my hand's going funny, then it's likely to be thoracic outlet syndrome. That's Morley's compression test. I won't do Gage's test, which is to inject the scalenes with local anesthetic. But otherwise, that's it. Right. Thank you very much. Back to your computer games. Thank you, Gus. Right, back to the screen. Okay, got all those? So I do all of that when I examine someone with thoracic outlet syndrome. Most of the time, they're negative, but you'll pick up some. If you examine normal people without any symptoms, one of these will be positive in half the population. That doesn't mean they've got thoracic outlet syndrome, although everybody has thoracic outlet syndrome. It doesn't mean it's pathological. The more positive tests you have, or the more neurologically provocative or provocative of their symptoms you have, then the more likely it is that they have thoracic outlet syndrome. Oh yeah. Okay. I always send my patients off for neurophys because I want to exclude carpal tunnel, cubital tunnel, or some weird neurology that they may have. And I always organize a C-spine or chest X-ray to look for cervical or first rib, and an MRI scan. Cervical ribs are reasonably common, slightly more common in people with thoracic outlet syndrome, probably because it's an indicator of a greater degree of anomaly in the thoracic outlet, because muscles originate from the C7 lateral process, and the origin of the muscle will change if they have a rib in situ. A little tip, if you're looking at a cervical spine X-ray and you don't know which one is C7, C7 has a downward going transverse processes, whereas the others have, thoracic ones have an upward going transverse process. Here's a cervical rib, and you can see that here as well. I organize an MRI scan. It's mainly to exclude cervical disease. So I'm looking for radiculopathy or some cord problem. I always ask for an MRI of the brachial plexus, but it's almost invariably normal. Even papers that are very pro MRI, like this one, where they reporting lesions, only find positive lesions in a very small number of people. So they had 30 people they diagnosed with thoracic outlet syndrome, subjected all of them to the MRI scan. 7 of them showed abnormalities, and 7 had an operation and were better. The other 23 out of 30 were discharged, and no idea what happened to them. They're probably still suffering. Here's an MRI scan. So you can just see, again, it's very rare to see that as the middle trunk comes down, here's a kink where it passes over the tip of a cervical rib. It's pretty uncommon to get a positive scan. So positive scan is very positive. Okay, I don't know how to go to the next slide. Let's do that. Positive scan, and like positive neurophysiology, is very positive and puts them into the obvious bracket rather than in the dubious bracket. If I'm very uncertain, I'll get a second opinion. That second opinion might be my own second opinion, in that I'll see the patient again or again until I'm convinced, and sometimes they change their story or change their presentation, or things become more obvious with time. Whilst all of that is happening, they go for therapy in order to try and improve their posture, improve their parascapular muscles, stretch their scalenes, stretch their nerves so they don't suffer from nerve tension tests. The ultimate examination, of course, is to do surgical exploration. And that's how I describe it to my patients. I say, I think this is what's going on. There are no more tests that will help to determine this. The only way to determine it is for me to open you up and have a look inside. And if I look inside, then I can see what the problem is and I may be able to fix it. There are a number of approaches for thoracic outlet syndrome. All of these ones from the back, from the axilla, from above, from below, the clavicle. But I think the optimal exploration technique is a supraclavicular approach. And the reason being is you then are able to see the pathology, remove the first rib if you need to, as opposed to a transaxillary approach or posterior approach. Patients positioned in a beach chair position like this, a little bit elevated, put some local in the skin crease in the neck, just above the clavicle, here. Skin incision through platysma, through the deep cervical fascia, sweep the supraplexural fat pad up. You don't have to divide omohyoid, you don't have to divide external jugular vein, you do not have to divide the supraclavicular nerves, they can all be retracted. And then you will see scalenus, and you may have to divide some fibers of scalenus, sternocleidomastoid in order to get medial exposure. And then you'll see scalenus anterior and the upper trunk of the plexus. This is anterior division. So that's posterior part of the plexus here, posterior division of upper trunk, anterior division of upper trunk, supraclavicular nerve, sort of said, heads up here, feet down there. Pull the plexus out the way, here's subclavian artery, scalenus anterior here, phrenic nerves in that corner. And the scalenus anterior is very thick and compressing subclavian artery. You can see how it's compressing subclavian artery here. So when the scalenes are tight, because she's lying with the head extended, turned away, that's very tight. And in fact, the deep fibers of scalenus anterior here are attaching to the dome of the pleura, not to the first rib. So they're creating a sort of a sling around which they can compress the subclavian artery. I then, so once I've released, I'd cut out a segment of scalenus anterior, usually the lower inch. I remove the part of scalenus medius that inserts onto the first rib. Don't go beyond the first rib because the long thoracic nerve travels through that. I then put my finger on top of the plexus, under the clavicle, and then abduct the arm. If costoclavicular compression occurs and it pinches your finger, then I take out the first rib. There's lots of space and the first rib stays in. Most of the time I take out the first rib. Take out the first rib extraperiosteally with the muscle and periosteum so that it doesn't recur. So here's another case. There's the posterior part of the upper trunk, anterior part you just can't quite see here. And I'm just showing you a tight band along the first rib and then the first rib removed. When you remove the first rib, I use upcutters. Do not use a power tool. I once tried to use a burr, wrapped the subclavian artery around the burr, had a really bad brown moment, and then, but luckily, once I unwound the power tool, the subclavian artery was okay. Better to be lucky than good. Here's another case just to demonstrate the plexus is here, artery is here, and there was a bursa on top of the apex of a cervical rib, which was displacing and irritating the vessels. There's the bursa open, and then once it's removed, you can see the dilatation of the artery. Here's another case. Oh no, it's the same one. I'll just get rid of that. This is to show you a scalenus intermedius. So this is the lower trunk here, coming down. This is T1, C8. And this is a abnormal muscle that's coming onto the dome of the pleura. There are lots of different types of bands and cords that are described. So Rouge described all of these, but actually they are so many because it just depends on all the variations that you see and can find when you're dissecting the plexus. They're not all predictable preoperatively, and so it just depends on your surgical exploration. This is another example of a scalenus minimus, also known as a scalenus pleuralis or a scalenus intermedius. And you can see it here going onto the dome of the pleura. This is the lower trunk deviating over the top. And then once it's removed. Another example here. So this is a tight cord coming and then compressing. Here in a cadaver specimen, just so you can see it more initially, this is scalenus anterior. This is a scalenus intermedius or scalenus minimus that's going through the plexus. So it's going deep to upper trunk and then superficial to middle and lower trunk. And it causes compression here. And often this element here is a bit compressed as well because it compresses the subclavian artery. So scalenus minimus, also known as intermedius or pleuralis. Just another example, just showing that this is where the normal muscle is, and T1 coming out here, C8 here. So that it's very hard to photograph or experience the plexus unless you're moving it around. As you can see, you can do it all through a pretty small hole, 5 centimeter cut. Here's so just going to try and demonstrate here. There's the plexus, its lower trunk. That's T1 here, C8 here. If I just, this is a tight band. So this is a scalenus minimus that's not going through the plexus, but is underneath the plexus. But it's going, it's a muscle that's a muscular tendinous unit that's going from C6, maybe C7 transverse processes and go onto the dome of the pleura here. This is the posterior division of upper trunk, anterior division of upper trunk. But here's T1 here, having to go over this muscle and so subject to compression or irritation. Vascular thrombosis is usually caused by a tight space between subclavius and scalenus anterior. There, okay. Good predictors of outcome. The more symptoms and signs you find, then the more likely you are to have a good outcome. But I sometimes get great outcomes in patients in whom it's a very EQ heavy diagnosis of thoracic outlet syndrome compared to an IQ diagnosis. And so the real good predictors of outcome are like this. There aren't any. Complications are uncommon, particularly in primary surgery. This is a pseudoaneurysm from an infraclavicular expiration in a patient with lower trunk ulnar disease, who convinced me to explore him. I don't think I did him any good, so his outcome wasn't great, and he got this additional complication of a pseudoaneurysm from a branch. It was low flow, surprisingly, but well demarcated. Other complications such as phrenic nerve division, hemopneumothorax, chyle leaks are all very uncommon, but do occur. This was to show you a decompression of this artery. I think we saw that before. And what do you do with recurrences? So recurrences I reassess from the beginning. And I get a lot of recurrences who've had primary surgeries and elsewheres, but also some of my own. Some of them do well for a period of time and then get recurrent symptoms. Sometimes the symptoms are different to the ones they had before. Sometimes they're very similar. Recurrences are commonly due to scar, recurrences of the rib, not so much a bony reformation of the rib, but a scar formation of the rib, or scarring around the plexus, which I think matures and then causes symptoms as the scar matures and contracts. The scalenus anterior often reforms and reattaches even after you excise the lower couple of centimeters of it. When I have a recurrence, I'll go through the same process to make sure of the diagnosis, do everything again, and then if it's indicated to do another operation, I do another operation, more of a neurolysis. And on this occasion, in order to prevent further recurrence, I put fat around the plexus, particularly around the lower trunk. And the fat I often use is this adipofascial delta pectoral flap, which is fat taken from underneath the skin based on perforators from the second and third interspace. So you lift up through the same incision, you can dissect through the deep dermis, and then just above pectoral fascia, take a tissue tissue fat like this, and then tuck it over the clavicle and into the hole. And here's another case where I did a supraclavicular and infraclavicular expiration, and there's the big lump of fat coming in, dissected from between the two incisions, going into the hole and then filling it. If patients are quite thin or they don't want the contour deficit that results here, then I'll sometimes use a free fat graft. And I have also on occasion used lipofilling, sucking fat from the abdomen, but I don't find that works so well. I have also in extremis done free fat flaps in radiotherapy situations mostly. And that is a quick whistle-top tour of thoracic outlet syndrome. I hope that has inspired you to think about thoracic outlet syndrome as a diagnosis when patients are not getting better from their carpal or cubital tunnel syndrome, or when their symptoms just seem a little bit weird, because I think a lot of them are dismissed when in fact they have a real problem that can be treated. Thank you.